Hello, everyone. Thank you all for joining or listening into the recording afterwards. This is our second webinar of Project REDDIE, fully named Real-World Evidence for Decisions in Diabetes. Today, we have an interesting topic, from data to discovery, introducing the REDDIE RWD Dashboard. Of course, before we start, there are some housekeeping rules that I want to mention. So first of all, if you have any questions, please use the Q&A section. We will definitely have a part at the end. We will answer all the questions, and feel free to, of course, be open to any answers, of course, you get. If you have any technical issues, please let me know. You can message me in the chats as well directly to me. As I mentioned, we will also have the recording of the webinar. This will be posted on the website of REDDIE. And you can also check out the first webinar recording as well, which is also available now. And of course, I ask you all to be respectful of the speakers and also fellow participants at all the time. So please be open and constructive in your dialogue and in your questions as well. So we are a consortium of 15, really across Europe, in UK and US. And our key objective is actually shaped into a question. So to help people with diabetes, how can regulators, payers, and guideline developers augment data from randomized controlled trials with data from other than RCTs to make decisions? We had some information about this as well in the first webinar, but today we will focus more on other objectives. This is also kind of a set of our sub-objectives that we have. So what we want to do is definitely support the use of RWD in diabetes, and hopefully this results in safer and more efficient and cost-effective interventions. We are also using data from 4 large national registries to elucidate the gap between outcomes in RCTs and RWD. And also, we have a team that is testing the ability of machine learning in this particular topic. And in the end, we will generate standards for RWD use, and some of this you will also hear today. I did mention that we are using data registries, and these are from England, Denmark, Sweden, and Germany. You will also hear today from our Stephanie that is also working for the German registry. But before that, you will hear more from what we are doing within Work Package 2. So I would stop sharing and introduce our Work Package 2 leader, Dr. Professor Pratik Choudhary, and his research associate, Thomas. I give you the floor, Pratik, first to give a bit of an introduction what we are doing in Work Package 2.
Thanks so much, Martina, for that introduction, and thanks to all our listeners for joining in this morning or sparing your time to listen to this webinar. It's such an important space, isn't it? We've got so much real-world data today across the world. And one of the things we wanted to do in this work package was try and find out if we can come up with a system to quality control that data, if you're using these data, to find out what data is out there, but then also to figure out how can you assess which data is most appropriate to answer the question you have for real evidence. And so that's the task, and my colleagues Jonah and Stephanie will be talking about all the work they've done over the last couple of years in moving this forward. So I'm gonna hand over to Jonah first up, and then we'll move to Stephanie to tell you a little bit about what we've done there. Jonah.
Thanks, Pratik. Yeah, and thanks everyone for tuning in today. So I'm just gonna get my slides up and running, and then we can. I'm hoping you can all see these okay.
Yeah, it works.
Fab. So as Martina kindly mentioned, our title for today is From Data to Discovery, and we're going to introduce the REDDIE Real-World Data Dashboard. And after this, I'm also going to briefly talk about a tool we have created to assess the fit for purpose of real-world data databases before handing over to Stephanie. I thought it might be worthwhile just providing a brief definition of real-world data. So the US FDA describes real-world data as data in relation relating to patient health status and or delivery of healthcare routinely collected from a variety of sources. So it's a broad definition, and it gives us a lot of range in terms of what databases could be considered real-world data. And we can see underneath in this graphic by Swift that there's a lot of databases that could feature here. So we have clinical databases such as electronic health records. We have medications such as prescription databases. We might have medical claims. We might have genetic and genome databases. We might have mobile health, data from fitness trackers and wearables, patient-reported outcomes, even things from social media. So we can see there's this huge breadth of real-world data that could be on offer to us. And Work Package 2 is all about collating what data is available in the diabetes space and then understanding how best we can utilize this. And again, just briefly, what are some of the benefits of real-world data? So real-world data can complement the findings from RCTs. So it might not be able to fully replace RCTs, but it can certainly complement the findings that we see from randomized controlled trials. It can answer research questions that may not be possible or ethical to answer with RCTs, and it can also save us time and cost compared to RCTs. It also offers us a very large sample size in some cases, and it can include individuals that might not traditionally be included in clinical trials. So as a bit of background, real-world data can offer many benefits to research payers and regulators in the field of diabetes. However, there is not currently a central repository of real-world data databases that exist globally for people to understand what data is available to them to answer their specific research questions. And therefore, we aim to conduct a systematic review to identify real-world databases in the field of diabetes. So we knew there were many databases available globally, and our understanding was that each of these would have their own strengths, limitations, and unique characteristics based on what data they collected, the individuals they collected this data on, and the methodologies they used to collect this data. We ran our search across 3 databases. We searched Medline, CINAHL, and Embase for relevant research publications. And from these, we were going to extract the databases that were of interest to us. Publications had to describe a real-world data database. They needed to include more than one observation. They had to be longitudinal in nature in some sense. It couldn't be a cross-sectional database. They need to contain at least 1,000 participants and include at least 1 year of follow-up. And we also said we wanted them published in the last 5 years because we wanted to make sure this repository was up to date and recent, and the databases included were still being maintained and were still relevant to the field. Due to the large number of databases we expected to receive, we excluded pediatric or gestational populations. These are obviously very important, but just for this particular review, we didn't have enough capacity to include these here. And we didn't include systematic reviews or protocols. You can see even with these inclusion criteria, we imported a large number of references, over 23,000 references. We did an initial deduplication, and then we also went through and removed any that didn't mention having more than 1,000 participants in their abstract, and this got us down to over 14,500 still. So we did title and abstract screening of 14,500. We did full text screening of over 2,000 papers, and that identified 573 databases, which we took forward into our review and into our online dashboard. Just to quickly summarize the results of the review, we can see here a map of the world with the countries colored by how many data sets were present within each country, with a darker red color indicating a greater number of data sets. And the key takeaway message here is that North America, Europe, and Asia had a large number of databases present within them across different countries, whereas South America and Africa had far fewer databases present. Here we can see the variables that were collected across each database. We can see here that we have demographics, such as things like age, sex, ethnicity. We had prescription data, so what drugs the person had been prescribed. We had diagnosis data. This wasn't just about their diabetes diagnosis. This is also if they had another diagnosis, such as cardiovascular disease or stroke. We had biochemical data, which includes things like HbA1c, cholesterol, EGFR. We had mortality data, so related to death. And we had technology-related variables. So this was things like CGM usage or insulin pump usage. And what we can see here is demographics, prescription, diagnosis, and biochemical data were commonly collected across the databases we identified, with mortality and technology data much less commonly identified. Now you can see each of these bars is colored by the continent of data collection. This tells a slightly tricky story, but the main takeaway message here is that actually the proportion of data sets that collect each of these variables across the continents is the same. So there's not a lot of disparity between what is being collected across the continents. It's relatively consistent. So roughly the same proportion of data sets are collecting demographics in North America and prescription in North America. So moving on to the REDDIE real-world data dashboard. So this was created at the end of our review to try and showcase the results and make them available to the broader research community. If you'd like to visit this review, it is live online. You can use the link here in the bottom left-hand corner or the QR code in the bottom right. And this is the home page of our dashboard. And you can see it tells you how many data sets are present, so the 573, the number of countries data was present in, which is 58, and it goes through, as we saw in the previous graph, how many data sets had demographics, prescription, mortality data. On the second page of our dashboard, we then have a table which outlines the number of data sets present for a number of subcategories. So we have the continents of data collection shown here. We also have the different populations, and there's many more splits this table offers for you to look at. It gives you the number of data sets as well as the number of participants we identified. This number of participants is very likely double counted, and this is where an individual will feature in multiple databases within a subcategory. So for example, there may be a prescription registry within a country as well as a diabetes registry, and the person may be present in both. So therefore the number of participants is likely inflated to the true number. We still think it's useful to understand this and see how many unique records are present within each of these subgroups. Finally, and hopefully this is the thing that's most useful to the research community, we've put together all of the data we collected is available on the dashboard in a table. And this table can be filtered down based on the continent of data collection, the country, the type of data, the population, the number of participants, start and end years, and what data was collected. You can also filter this by the access status as well, whether it was open, on request, or closed. And we think this is really useful for researchers because you can look and see, I'd like to ask my question, and I'd like it to be in data sets collected within Asia, and I'd like at least over 10,000 participants in each of my data sets. And you can filter this down and it will give you a reduced subset of our data, showing you how many data sets meet those criteria. So overall, our review identified a wide range of data sets, each with unique strengths and limitations which are available globally. We can see that demographics, prescription, diagnosis, and biochemical data were frequently collected, but variables relating to technology and mortality were less commonly collected. There's a paucity of data collected in LMIC nations, particularly in Africa and South America, and this suggests a potential lack of representation in these areas, and it may be worth future data collection efforts to focus on these areas to fill that gap. So overall, we hope this review will save future researchers time and resources by understanding the breadth of databases available. The online dashboard, we hope, provides a valuable resource which identifies the potential gaps in the current data collection, as well as what is available to answer individuals' specific research questions. I'd now like to move on to talk about assessing the fit for purpose of these real-world data databases. So we identified this very large number of databases, and it shows there's a huge amount of real-world data available that may be useful to answer research questions related to diabetes. However, researchers would need to narrow down which database they may be interested in before they can begin answering their research question. And we felt a structured process could be followed, which would help alleviate bias and show transparency in the selection process as to which datasets were being used to answer which research questions. A number of tools have previously been developed to do this. So there's the SPACE and SPIFT tool, and this tool focuses on initially defining a research question, operationalizing and ranking the minimum criteria that a database must have in order to answer that question, identifying and then narrowing down the data sources that could be viable based on that minimum criteria, and then a detailed feasibility assessment is conducted to figure out which database may be best suited to answer that specific research question. So you see, this is quite a lengthy process and it has many stages. It is a good tool, and I'll talk about some of the limitations in a second. Another tool that's been created is the fitness quotient. And the idea here is that you set a number of threshold values for what would be considered best, good, and fair for a number of variables. We can see here the number of patients in the intervention arm. The best would be 1,000 patients in that arm. They're talking about the mean number of days of history prior to index date being 10,000 being the best. And then if a data set meets this criteria, that data set is awarded a certain number of points. We can see for the best here it's 9, for good it's 6, and for fair it would get 3. And this would allow those totals to be summed for each data set. And that obviously gives the data sets a ranking as to how appropriate they are to answer the research question. So these tools help researchers understand which databases may be appropriate to answer their research question. However, these tools do not provide clear or rigorous methodology explaining why they were developed in the way they were and why certain scoring systems were used, for example, or why certain criteria were put in certain places. Further, they're very research focused and they don't consider the views of regulators, payers, or industry professionals, which are really important in real world data. And therefore, we aim to develop a tool to assess the fit for purpose of real world databases that use this more rigorous methodology and also encapsulate the views of regulators, payers, and industry. So the methodology we decided to use was a concept called group concept mapping. And this methodology uses three main stages. It's a mixed method approach, where the first stage is brainstorming. So you ask a number of participants, what would they consider important when deciding whether a database was fit for purpose to answer a research question. So the things that might come out here is number of participants, amount of missing data, what variables have been collected, for example. These statements are then taken forward and participants are then asked to sort these into categories based on how similar they are. So if they cover similar concepts. So for example, the amount of missing data, how frequently is data collected may all be categorized together into an idea of data quality. And finally, these ideas are ranked. So we asked participants to rank these on two scales. So the first was importance. So how important is the number of participants when deciding if a database is fit for purpose, for example? And then how feasible is it to assess the number of participants in a database? So they're ranking based on the importance and the feasibility of each of the statements produced. So we look to recruit participants with an interest in real world data, so some key stakeholders from both within the REDDIE consortium and beyond. We use online surveys to complete the brainstorming, idea sorting, and idea ranking in three separate stages. We made a lot of effort to try and engage with industry regulators and payers, and we did get some responses from them. However, our data was still heavily skewed from researchers. So it is worth noting that we did try to engage with these groups. However, we found it challenging at times to get the same level of response as we did from the research community. And this is sort of the key takeaway message from our results, which is called a go zone map. So along the x-axis, we have the average importance from all the raters for each statement. And on the y-axis, we have the average feasibility from all raters. And then you can see this graph separates into 4 color-coded squares. So in the bottom left, the pink square, we can see statements that weren't rated very important or very feasible to collect. In the bottom right, we can see statements which were deemed to be important, but not very feasible. In the top left, we can see statements that were feasible, but not very important. And then the key box for us is the light blue box in the top right-hand corner. And this was statements that were judged to be both important and feasible by our raters. So each number here represents a statement. So all of the statements that were included in this top light blue box were taken forward from this process and then used to create our tool. And these statements are listed here. So the number of participants, is the data longitudinal, the extent of demographics, the variables that are present within the database, the representativeness of the data, what is the coverage duration, what are the inclusion and exclusion criteria applied to the database, what's the database's coverage, how granular is the data, how frequently is that data updated, what is the data collection methodology used, what is the population covered, and is data linkage possible? So these were our 12 statements which we then took forward when we were creating our tool. And this is the tool we came up with. So we split it into 3 categories. So we said the first important step is defining your research question. And to do this, we used the PICO or PECO model, and we added some extra questions to it based on our responses from our group concept mapping process. So we had, what is your population of interest? Does the analysis have any inclusion/exclusion criteria? What duration of follow-up do you require? What outcomes variables do you want to examine? What sample size is required? Who will you compare against? So what will your comparator be? What explanatory variables do you want to examine? And are there any potential confounding variables? Once you've defined your research question, we then suggest you do a data extraction process on the databases. So what population does the database cover? How well do the sample characteristics match the population? What duration of follow-up is available for that database? What is the sample size? What variables are collected within it? How often are these variables measured? And how are these variables measured? So what's the methodology of data collection? And if variables are not included in the database, can they be linked using other sources? So that's the is data linkage possible question. And then finally, we suggest that you assess the fit for purpose by saying, does your database have a representative population? How many people who met your inclusion criteria are present within your database? Do you have sufficient follow-up to answer your question? And does the database contain necessary variables, so your outcome, your explanatory, and your confounding? And this is just a quick example using one of the questions we had from REDDIE. So you can see this is defining the question. So we can see we have the population. So for REDDIE, that's people with type 2 diabetes. We then have some inclusion-exclusion criteria based on what drugs the individuals are taking, as well as their age. We said a minimum duration of follow-up of 3 years. We said our comparators individuals on DPP-4, and our exposure was GLP-1. Our outcome was MACE and cardiovascular outcomes. We wanted at least 1,000 participants, and then we had a list of potential confounding factors that were of interest. You can see we then went through each of the national databases, which Stephanie will talk about in more detail in a second, around the Swedish National Diabetes Register, DPV, Danish Adult Diabetes Register, and the NDA. And we then pull out these key characteristics. How many individuals are included? What is their duration of coverage? So we can see DPV started in 1995, whereas the NDA began data collection in 2003, for example. So we can start to see the differences between these databases. And once we have all this data, we can then go through, and we can start to look at, are our outcomes present? Are our covariates present? What are the differences between these databases? And by asking those 4 questions at the end, we can see which database may be most suitable to answer our research question. So in summary, Work Package 2 already has produced an online dashboard which outlines the key characteristics of real-world databases within the field of diabetes. We've then produced a tool to assess the fit for purpose of these databases to allow regulators, researchers, and payers to make informed decisions regarding which database is best to use for their research question. And in the next year, we're looking to produce guidance around harmonizing real-world data to increase its utility to answer research questions. Thank you for your attention, and if you have any questions, I'll be more than happy to answer.
Great, thank you very much, Jonah. I would like to ask a question. What would you say was really the biggest challenge of producing this dashboard? And I know that you got a lot of data sets at the beginning, which took a lot of time as well, but were there anything else that will help this dashboard to get even better?
Yeah, I think there's a couple of things. I think there's obviously the number of return results was very high. And I think that presented a real challenge in terms of, do we go for breadth or depth of data collection? So if we had a very small number of databases, we could have done a real deep dive onto their characteristics and provided a really detailed oversight into each one. When we were receiving so many back, we had to make the decision to go more for breadth and have a large coverage. But actually, we could only say, there's demographics present here, there's prescription data present here. We couldn't say specifically in more detail how those things were collected. And that sort of leads on to the other main challenge, which is keeping this up to date and keeping this sustainable going forward is a big challenge, because each time you rerun that search, you're getting a couple of thousand more publications, a couple of hundred more databases to be added. So we are in discussions around how best we can do that, but it's certainly something we're trying to explore is good ways to maintain the sustainability, because just me going through each year is not the best approach.
Yeah, of course. And what would you say, would further feedback from different stakeholders, especially regulators, help as well?
Yeah, definitely. I think we're really keen to get feedback from researchers, payers, regulators regarding what would be most useful for them. I think we've made we very much see this as a sort of a first draft. This is our initial results from the review, and it's what we think would be useful to people. But we're very keen for people to come back to us and say, well, actually, this part's useful, but we'd actually really prefer this layout, or you haven't mentioned this variable, and that's of real interest to us right now. We think this would be important going forwards. So we're very open to those sort of those comments and pieces of advice, and we try and include them as best we could.
Perfect. Thank you very much, Jonah. If anyone has questions, feel free to put it in the Q&A as well. And of course, if you want to reach out to Jonah or to Pratik to talk more about the RWD dashboard and maybe some feedback and so on, feel free to pop your email in the chat, or feel free to reach out to me as well, and I can then connect you as well. And now we go to Stephanie. Dr. Stephanie Lanzinger is currently heading the registry research group at Ulm University Institute for Epidemiology and Medical Biometry. She is also working within one of the European National Diabetes Registers that we use for REDDIE, but I will give the floor to her because she will explain it much more better than me. So Stephanie, feel free to start the presentation.
Yeah, thank you very much, Martina, for this nice introduction. So I'm very happy to give you a more detailed description and comparison of the registries that are included in the REDDIE project. So I hope you can see my screen now. Okay.
Yes, it works.
Perfect. So okay. So I would like to add on a bit on the points that already were raised by Jonas on the comparison between real-world data and randomized controlled trials, the strengths and limitations of both topics. So in recent years, there is an increased attention and recognition of real-world data and an interest in using real-world data for studies. But of course, randomized controlled trials are the accepted gold standard to investigate efficacy and safety of new therapeutic agents. But on the other hand, randomized controlled trials are often limited because due to strict inclusion and exclusion criteria, the representativeness of participants is limited, and randomized controls are followed by regular intervals, so represent controlled environments, whereas real-world data include routinely collected information in registries and therefore can complement the results of randomized controlled trials. Here we can see a comparison between randomized controlled trials and observational studies that can be conducted using real-world data from registries. So for randomized controlled trials, the study type is of course experimental and interventional, and in observational studies, observational and non-interventional, and observational studies are also more flexible with regard to the design and also the study population. So we can use a, in general, diverse and generally unrestricted population in observational trials, versus in RCTs, the population is restricted due to the strict inclusion and exclusion criteria. Randomization is possible in RCTs, but not in observational studies. Outcomes are clearly defined in RCTs, and in observational studies we can in general also study a relatively wide range of outcomes. Blinding and drawing of causal inference is only possible in randomized controlled trials and not in observational studies, and of course this is a point we have to keep in mind when interpreting results of observational studies. So here again, the strengths and limitations of RCTs. RCTs have a lower diversity with regard to the demographic characteristics, often include a younger population and to a lower extent older population or pregnant women or very small children. And therefore, RCTs are limited with regard to the representativeness and the generalizability to a more general population. RCTs often evaluate interventions under ideal conditions, while observational studies examine effects in real-world settings and can increase the generalizability. So real-world data can complement the results of RCTs. So on the one hand, we need, of course, the RCTs with regard to the validity, the internal validity. RCTs have a high internal validity, but on the other side, observational study can complement these results by increasing the external validity. So here we can see a very nice manuscript using data from the UK. The aim of this manuscript was to study the generalizability of the clinical trials REWIND, LEADER and SUSTAIN to the real-world type 2 diabetes population in United Kingdom. So the main focus was to determine the proportion of adults with type 2 diabetes from a large national representative sample in UK who meet the cardiovascular risk profile defined by REDDIE Leader and Sustain 6. And one of the main results of this publication was that REDDIE represented the most generalizable population, the more representative population of the real-world type 2 diabetes population in the UK compared to the other trials that were investigated in this article. Okay, coming back to our registries. So here we can see a picture showing several sources of real-world data, and of course the disease registries are one of the important sources for real-world data. Using registries, we can study research questions focusing on routine clinical care in real-world settings. And before we introduce the 4 registries, we will have a short look into the current prevalence of type 2 diabetes in Europe. So in Europe, in the adult population between 20 to 79 years of age, we have a regional prevalence of 9.8%, and this refers to 66 million people with diabetes living in Europe. And it is projected at the moment that this prevalence will increase to 11% until 2050. So at the moment, 1 in 10 adults have diabetes, which refers to 66 million people, and 1 in 3 adults living with diabetes are undiagnosed. 1 in 7 live births are affected by hypoglycemia in pregnancy, and number of people living with type 1 diabetes in Europe is currently estimated to 2.7 million people. So as introduced by Martina, the REDDIE project, one general aim is to use real-world data to advance research related to diabetes, and one of the main objectives is to emulate clinical trials using real-world data from registries. The focus is on adult individuals with diabetes. And using registries, we will do a target trial emulation. So we will use registry data in order to emulate clinical trials. For example, the EMPA-REG outcome trial, which focused on empagliflozin in comparison to placebo and investigated cardiovascular outcomes and mortality in type 2 diabetes. Another trial that will be emulated is the LEADER trial, which focused on liraglutide and cardiovascular outcomes in type 2 diabetes. And within registry, we will also emulate trials focusing on metabolic outcomes, such as the LEAD-2 study, which studied metformin in combination with liraglutide or glimepiride in type 2 diabetes and investigated the effects on HbA1c and BMI. So based on the variables that are available and based on the strengths and limitations of the respective registries, we will emulate several trials in the REDDIE project. So the 4 registries that are included in REDDIE are the Danish National Administrative Registers with information on hospital admissions, prescriptions, death and socioeconomic factors, the Diabetes Prospective Follow-up Registry with centers predominantly from Germany and Austria, the Swedish National Diabetes Register, and the National Diabetes Audit for England and Wales. And I will shortly show you some important points of these 4 registries. So for Denmark, we have the Danish National Registers. First, the Danish Adults Diabetes Register, which was established in 2004 and contains information from hospitals and general practitioners. We also have the National Prescription Register since 1995, the Danish National Patient Registry, and also some other registries for cause of death, civil registration, population education, income and laboratory information system databases. And in Denmark, linkage between these all registries is possible using a civil personnel register number. So this is one of the main strengths, that all these information, all these registers can be linked in Denmark. The Diabetes Prospective Follow-up Registry it was established in 1995, had an initial focus on children and adolescents, and later in 2000 was extended to adults. So data from hospitals and practices specialized in diabetes are involved in the DPV registries, and centers are located predominantly in Germany and Austria. And there's also 1 center from Luxembourg and 5 centers from Switzerland. So here in DPV, all information relevant to diabetes and also comorbidities are collected. Also laboratory data, treatment, medication and comorbidities are included, and data comes together from all the centers at Ulm University. So twice a year the centers transmit their data to Ulm University, where data are aggregated to a anonymized database. The National Diabetes Audit for England and Wales, NDA, collects data from general practices in England since 2003, and data is collated centrally with other sources from secondary care. Additional models have been added from time to time, including data from hospitals on pregnancy care, food care, and also insulin pump use. And also the documentation of specific therapies is possible since 2017. Eye screening information has been added recently, and also in England and Wales, data between these registries, between different data sources, can be linked. So also, for example, linkage to civil death registration by a pseudonymized NHA number. So here also we have the advantage to link several data sources together. Swedish National Diabetes Registry was established in 1996 and contains detailed information on diabetes care. Data is registered during routine clinical visits in primary as well as specialized care. Clinical measures are recorded, and also diabetes complications, micro and macroalbuminuria, and information on lifestyle factors. And like in Denmark and England, Wales, in Sweden, also linkage to other registries is possible through a personalized personal identifier. So data can be linked to death registry, patient registry, prescription information, and to the longitudinal integration database for health insurance and labor market studies. So here the unique characteristics and common variables in the 4 registries are visualized. So in principle, in all 4 registries, we have information on cardiovascular disease, demographics, technology usage, and smoking status, but there are also some strengths and limitations. So in the DPV registry, we have information on CGM variables, but DPV does not contain mortality information. Mortality information is provided by all the other registries, and in all the other registries in Sweden, England, Wales, and Denmark, linkage to other data sources is possible. And in this registry, there is also a near complete population coverage. So here we see the key variables and also the information whether these respective variable is collected in the respective data sources. So with regard to laboratory measurements as HbA1c and BMI, this information is collected in DPV, NDA and Swedish NDR, and also partially collected in the Danish registry. Diabetes technology is fully available in the DPV registry and also partially available in the other 3 registries. But as I already said, in DPV, we do not have information on mortality, as can be seen in this slide. Mortality information is present in Denmark, England, Wales, and Sweden. And also cardiovascular disease and other complications are documented either directly in the registries or are available through linkage to other data sources. So to sum up, the 4 registries that are involved in the REDDIE projects provide broad population-based coverage of the European population, adult European population with diabetes. Based on data that are available, each registry has unique strengths and limitations, and also these 4 registries complement each other with regard to the information that are available on a full extent. By combining these 4 registries and by comparing the results, each registry can showcase their respective strengths, and whilst any limitations of one registry can be covered by information from the others. So, and with this, I would like to thank you very much, and I am open for questions.
Thank you very much, Stephanie. I do have a question while we wait maybe for the others as well to send in their questions. So you mentioned all the similarities and differences within the each of the registries. What was maybe the most surprising for you that you saw from your perspective as a researcher as well?
Yeah, well, it's that, yeah, it's really how these different variables, of course, are defined, and also that, of course, in every registry, the aim is to improve diabetes care, but also every registry has its own focus on certain outcomes, and yeah, I think this was interesting in order to set up which registry is best for emulating hard outcomes like mortality and cardiovascular factors, but other registries are more important for, or more strong for implementing clinical trials on metabolic outcomes. So it was really very interesting to study about these differences, and I can say I learned also a lot while talking to other representatives from other registries. It also gives us the possibility to improve at some points. Yeah.
I think the same question also goes to Pratik and Jonah, because they're also working from the UK side of the registry. Do you see any surprises for you as researchers as well in the registries and the data that you are working with?
I don't think we see surprise. I think there's differences in all the databases. So as Stephanie said, for example, the German database is entered in by clinicians. So there's some data that's present there that we don't get in the UK database, but the UK database is just broader and involves everybody in the country. So I think understanding the differences between those databases is really important, and that's why in this REDDIE project we've chosen 4 databases, because we know we're going to get slight differences in the results because of the way those databases are created. And this is a really important point in real world evidence, as this, if you look at our overall aim of how we can help regulators, researchers, and clinicians understand the data. We get lots of analyses nowadays of real world evidence being published, and you really need to understand how those data were created. And that's where Jonah's fit for purpose tool becomes really important, as you understand, is this data fully representative? What's the coverage of the data? how real time is it? How often is it updated? These are really important questions when we are analyzing and interpreting the outcomes from these data. And I think in this world now, in the last 3 years, as a clinician, I was reflecting on this. What I currently do in clinic as best practice is so different to what I was doing 3 years ago, which was so different than what I was doing 6 years ago. The pace of change and innovation, particularly in our field of diabetes, is so fast that RCTs can't keep up. And a lot of new innovations are coming into real world evidence. So we think this use of real world evidence is really important as long as it's understood with the right caveats and thoughts. I'm just wondering, does anyone else on the call have any questions? Want to put their hand up? We'd love to have some input from people. We have a bit of time.
If not, while we wait, maybe Joanna, if you have any other comments as well on the question.
I suppose anything I was going to add is that it gets really interesting when you start looking into the real world data within each database. So at the minute we're working on the CPRD database. And for example, I think we found something like 55 different units of measurement for HbA1c within that database. And it's typos and it's it's slight tweaks to somebody puts a comma somewhere, someone puts a slash, someone doesn't, someone uses a capital letter, someone doesn't. And you end up in a situation where, although your total missing data is very small, actually when you come to a data cleaning task, it becomes very complicated, as Pratik was saying, by whether that's entered by a machine or by a person and slight changes. So you get the overall picture, I think, from the stuff we're doing, but then there's additional complexity when you get into it.
Great. We have a question from Kelly.
Hello, thank you very much for this presentation. It was very interesting. I work at the European Medicines Agency and I do a lot of work related to registries, patient registries, and I'm actually involved in another material cluster, which is more Europa. I had a question, actually two questions. The first one is, did you go into the level of details of data quality? So like looking at the percentages of missingness of the data, completeness, all this, understanding how long is the data, do we need to wait for the data to be available in the registries, all these kind of things that are actually, elements that we have described in a document called the Data Quality Framework. So that's my first question. And the second is, what are the next steps with this project? Are you really planning to actually do the target trial emulation based on the databases you've identified as the most fit for purpose? Thank you very much.
Jonah, do you want to talk about the? Jonah, do you want to talk about the data quality framework? Give a look at that.
Yeah, I think that's really an excellent point, Kelly. And we didn't get a chance to go into looking at the data quality of each database. I think, as I mentioned before, because we had such a breadth of data, we weren't able to dig into the level of detail that perhaps we would have liked to for each one. I also think there's potentially a question around access to data in there. So it's hard to assess. A lot of the databases were closed or had restricted access. Very few were sort of very open regarding allowing obviously access to the data because it's patient level data. It makes perfect sense, but it does restrict us in our ability to actually assess the data quality before we dig into it in a lot of detail, which I think is potentially an issue for real world databases, because it might look fantastic from the outside. It's collected loads of variables. If there's loads of missingness in there, and like you say, if the data quality is not up to standard, then you might make a lot of effort to access the data and then actually find when you're in there that the quality is then lacking. So I think potentially those markers of data quality we can pull out from databases and have databases maybe reporting those sort of metrics would be really important for the field going forward.
So, and with regard to the publication, of course, we are working on this target trial emulation, and so Christian and Katrine from Copenhagen are also in this call, and they are in Denmark. They developed an R package, which we use for target trial emulation. And of course, we will publish these results. So every registry with certain clinical trials, and we'll compare these results with real-world data, which was shown in clinical trials. Of course, we will also publish that and yeah, discuss that openly, of course.
Yeah, Kelly, can I come back?
Yeah, sorry. Thank you for these responses. Just to follow up, we are also doing some work on target trial emulation, some studies, etc. And I think going forward, it will be very interesting to keep in touch and share the learnings from these studies. So
yes,
yeah, happy to take it offline and
yeah,
because it will be nice to grasp all the challenges and yeah, and discuss about them.
Yes,
Thank
yes,
you.
of course. Yeah, that would be really interesting, and also what method you will use. And I think this would be nice, yeah, to keep in touch and discuss.
Perfect. I believe you have my details, so
Yeah,
feel free to
perfect.
contact me. Thank you.
And Martina, we have a webinar on target trial emulations also that might be relevant to what Kelly's asking.
Yeah,
further
I did
details?
share in the chat the recording of our first webinar, which was actually explaining the method behind it and how everything is working. So Christian, which Stephanie also mentioned, he's the work package 4 leader that is leading through all of the registries to this work. And he also explained how this is going in that work package and what we are doing there. So feel free to listen to the recording. After this webinar, I will also send both of the recordings to all of your emails, so you can definitely check that out. But yeah, definitely happy to organize more meetings to discuss in details and see what's happening. I would say within the whole material cluster, we do have additional stakeholder meetings, which we can also invite you to, where we share all the results and what's happening currently and all the challenges as well. I would say every project has them as well. Yeah. Any more questions maybe from the participants currently? Okay, if not, as I said, feel free to reach out to us. Also, you can check out our social media as well, where we will have more webinars. As Stephanie mentioned, we will also share more of the results from each of the emulated trials that we are doing. And of course, when we go fully into the guidelines that we also need to produce, we will also have some webinars on that part. And yeah, thank you all very much today from all of the presenters that we have. Thank you, Pratik, Joan, and Stephanie. And yes, see you in the next webinars on our socials as well. And have a nice day and a productive week. Thank you all.
Thank you. Bye.
Bye.
Thank you. Bye.